Thank you, Dr. Natasha. So, we'll be discussing how to evaluate the pupil and how to find out if there is a problem associated with the quality of vision which is associated with the pupil, and how to approach these cases. So, I do not have any financial disclosures in this case. And initially, if you have to evaluate vision, it goes through a series of steps. So, from assessing visual acuity and broad terms of vision like stereopsis, color vision, we get into assessing the quality of vision layer by layer. So, the tear film is assessed usually by interferometry and OCAS and tear film changes. And then when you assess the cornea, it's by topography and corneal aberrometry. And when it comes to pupil, usually we have two aspects of assessing the pupil. One is the pupil size and its changes, and another is the aberrometry related to the internal aberrations. And beyond that, in the retina, we have other higher grades of vision in the form of macular function tests and contrast sensitivity. So, looking at how we assess the aberrations and quality of vision. So, we have two entities called PSF and OTF, which are basically point spread function and optical transfer function. So, point spread function is when a ray of light goes into the eye, how that specific point of light is reflected onto the retina. If you have a point focus of light focusing on the retina as a single point, that means you have a perfect optics, but usually it's not so. There is usually a derangement in the point spread function, but how much of it is deranged is what makes a difference. And optical transfer function or modulation transfer function depends on how much of contrast is changed between the object to the image. So these things can be specifically looked for in the pupil or the internal aberrometry. And when it comes to pupil size measurement, many of our topographers and other pupilographers will be able to give us scotopic, photopic and mesopic pupil sizes, and also a dynamic change in how the pupil size changes over time. So with this is in respect to the light reflex. So in different phases of the light response to the pupil, you will have, say, the highest size in the scotopic phase, and then the smallest in the photopic phase, and then also a dynamic pupillometry, which is important because especially in multifocal IOLs and different scenarios with respect to corneal presbyopic lasers, you need to have your pupil that dilates and constricts with the near response. So in these cases, if the pupil is not responding well, then you should be able to diagnose these and find that as a cause. And the next important thing is assessing the near response. The pupilographers assess the light response, but if you have to actually assess the response of, we have two types of response of pupil. One is in response to the light and the other is in response to accommodation. So if you have to accommodate, find out how much the pupil is accommodating, then you will have to do a dynamic aberrometry or a dynamic accommodation study, which is given by Osiris-T. So in response to a stimulus, which is an increasing grades of accommodative stimulus from 0 to 3 diopters of stimulus, which is marked by the red line, you will be able to see how the pupil changes with the stimulus. As the patient tries to accommodate, how the pupil changes, and the blue line that comes up now is how the actual accommodation of the lens happens. So that is a function of the internal defocus and spherical aberration change. So if you look at this graph, which is the final output, you find the stimulus, which is a 3 diopter stimulus, and the blue line is the lens change, and the green line, which you see the green curve, is how much the pupil changes. So some patients may have a normal light reflex but an abnormal near reflex. Some patients the normal near reflex but an abnormal light reflex, which we have studied as Argyll-Robertson pupils and different kinds of scenarios. So these things can be objectively assessed by dynamic pupillometry. And with respect to higher order aberrations, pupil and quality of vision, many people make a mistake that they start diagnosing, they look at an aberrometry and say this patient has a lot of internal aberrations. But the other important factor that they miss out is what is the pupil size. So at this pupil size of 2 mm, this patient has negligible aberrations. You would think that this patient has a perfect optics. But as you go further at 3 mm, at 4 mm, and at 5 mm, and when you go to 6 mm, it looks much more aberrated. And you can see the quality of vision, the E chart that is shown, the simulated E chart, gradually changes in contrast and changes in quality. And the point spread function also changes. So at this point of time, you should be able to understand that the optics and the pupil are interrelated. It is not that they are distinct entities. A person with a highly deranged optics can have a good quality of vision, the pupil size is relatively small, whereas a person with not a very bad optics can have a really bad quality of vision, the pupil size is larger. So you need to have match of these two, and let's look at what's the third now. So these three things have to be together to have a patient in actual distress, but an optics and pupil alone can itself cause a significant level of problem. So let's look at this scenario. We understood what is point spread function. So if a point spread function is like this, it is an ideal retinal point spread function, wherein it is only in theory, but we don't usually get such ideal point spread functions, which will give us a perfect, supposed simulated perfect E. But let's look at this scenario. We have two cases with such point spread functions. So anybody who looks at this will be able to tell you that the one on the right, the case 2, has a slightly deranged point spread function compared to the one on the left. But many others would tell it looks similar. And these patients have perfect 20/20 vision on quantity. And if you look at their topographies, and any refractive surgeon or cornea surgeon, the first look would tell that the one on the case 1 should be having a better optics compared to the one in case 2, because there is significant vertical coma in case 2. But if you look at which patient would have a better quality of vision, to your surprise, you would find that the patient on the right has a better quality of vision, who is expected to have poor quality of optics. So why and what is this difference due to? So the first difference we understood was that with respect to the pupil size, you will be able to have an optics enhancement or derangement because of the optics. So though we know that in both the cases the pupil size is larger, more than 5 and 5.5 in the mesopic pupil size, but still the patient in case 1 has a significantly deranged quality of vision. So if you look at how to assess the pupil related quality of vision, there is the other method that we have to look apart from point split function is how the phoropter related refraction changes over pupil size. So here you can see on the x-axis you have ranges of pupil size, and on the y-axis how the refraction changes with the pupil size. So if you have a green line which is the axis and the blue line which is the cylinder, and the purple line, if both of them are relatively parallel, that means with the change in the pupil size, the refraction is more or less similar. But if you look at the one in case 1, there is a significant change in the pupil, with the pupil size, there is a significant change in the astigmatism and in the axis. So in these patients, what happens, until a pupil size of 5.25, there is a relatively good quality of vision, and then it deranges abruptly, and these patients manifest. But if you look at it in the other patient, which is the case 2, you find that there is still a change, but this change is not so significant like how in the other eye. So though the pupil size in the first patient and the second patient were more than 5.5, both of them, but if you look at the patient of the first case, when we normally do an examination, this is an illustration, but when you do a slit lamp examination of these patients, we found that this patient had more and more rapid pupil movement changes compared to the one in the case 2 who had a good quality of vision. So we expected this patient should have some amount of, say, anxiety or some mental health problems or some problem with the mind. So when we examined further, we had the idea, can the personality of this patient be related to what the patient's experience of quality of vision is? And we have our basic scenario when we usually analyze the personality with the questionnaire. We found that this patient had an abnormal pattern. Let's not go into the details of assessment of that, that's a different topic. But this patient had an abnormal pattern of personality presentation. And these suggested that this patient could have an OCD. And then when we probed further, he revealed that he was on OCDs and SSRIs, and he had stopped treatment. So we referred him to the psychiatrist, and the psychiatrist on further probing found out that he was on a cocktail of 3 drugs: cocaine, alcohol and analgesic abuse. So these things were the ones that were causing him rapid pupil changes. So we have literature to support this, that as your eye, as a pupil size can keep altering with respect to your psychopathic state. And these patients, if you look at it at this point of now, the triad, the Venn diagram is complete when the mind is involved. The third part of it is the mind. So if you cannot look at pupil as an isolated entity. With the pupil, if there is an associated optical problem, and if that is exaggerated by the presence of abnormal personality in the form of mind, then you have a patient in perfect distress. And adding on to these patients, since these patients usually have a mind problem and anxiety and these issues, they also control accommodation apart from controlling the pupil. So these patients, a near vision triad is near reflex is a triad of these 3 phenomena. Not only is the pupil constriction affected, but also the lens accommodation and convergence, leading to blur in these patients' images. And if you do a detailed orthoptic evaluation, you would find more of a convergence problem and accommodation problem as well. And these patients will definitely improve with convergence and accommodation exercises as well. So when you look at a patient of having, you suspect a patient, you do not know what exactly is going on. Either the optics is very bad, but the patient has a relatively good quality of vision, or the optics is relatively good, well preserved, but the patient has a really bad quality of vision. In these cases, you should be able to understand which diagnostic modality to use and how to interpret them. And importance of pupil size has to be interpreted along with the optics, and importance of understanding the patient's mental status is very important. The interplay between the pupil size and aberrations, I hope the point is driven. And the role of mind is definitely something that the ophthalmologists have to look into when they assess these patients with the quality of vision not correlating well with the optics. And these patients always have an associated orthoptic issue which has to be considered. Thank you.